Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome back to the Deep Dive. Today, we are undertaking a deep dive into something that is rare, often silent, and yet it's one of the most immediate and deadly surgical emergencies out there, the internal hernia.
That's right.
We're not talking about those external sacs you can see. We're dealing with viscera that are hiding in plain sight, and they demand, immediate and really precise intervention.
Absolutely. And our mission today is to cut through all the noise and just deliver that high-value clinical knowledge, the stuff that clinicians really need to optimize diagnosis, to refine their surgical strategy, and maybe most importantly, to standardize how we prevent these in the first place.
And the stakes just couldn't be higher, which is why this is so vital for you, the listener. Here's the paradox that is just chilling. Internal hernias are rare, right? They make up less than 1% of acute abdominal cases.
Right, a tiny fraction.
But that rarity is immediately, and I mean tragically, offset by the mortality figures. We're talking about up to a 50% risk of strangulation.
50%.
And a potential mortality rate that can hit 30% if there's any delay in diagnosis. It's really the definition of a hidden killer.
It is. And given the intense clinical nature of this topic, we have to start with our explicit mandatory disclaimer.
Of course.
This content is for reference and informational purposes only. Surgeons, doctors, everyone listening, you must always adhere strictly to your local hospital guidelines, to established protocols, and to your own best clinical judgment in practice. Your local protocols always take precedence.
Okay, let's unpack this threat. When we talk about an internal hernia, what is actually happening inside the patient? And how does that specific location make it so much more dangerous than, say, a standard inguinal hernia?
So the entire key is the location. It's the protrusion of viscera, usually the small bowel, through an aperture within the peritoneal cavity.
So it's trapped inside.
Exactly. Unlike an external hernia, there's no way out. The moment that bowel herniates, it creates what we call a closed-loop obstruction.
And that closed loop is the core reason for the terrifying speed of progression, correct?
Precisely. That tight, narrow orifice, whether it's a natural space or a surgical defect, it acts just like a tourniquet. It restricts the passage of content, sure, but more critically, it restricts blood flow.
And the timeline on that is just frighteningly fast.
It is. Initially, you get lymphatic and venous congestion, so the bowel gets swollen and dusky. But that pressure mounts so quickly, leading almost immediately to arterial compromise, ischemia, and then necrosis. And since that orifice is so tight, spontaneous reduction is almost impossible. It makes urgent surgical release mandatory to save the bowel.
So if that aperture is the villain here, where do these defects even come from? The sources seem to break them down into two main categories.
That's right. You have your congenital hernias, which stem from, anomalous development, things like the classic paraduodenal types. Historically, they were the most common.
But that's not what's driving the conversation now, is it?
Not at all. What's really driving the current clinical picture and what we have to focus on is the huge increase in acquired or postoperative hernias.
That just reflects the reality of modern surgery, doesn't it? As these complex abdominal procedures become routine, we're creating more of these potential defects.
Exactly. Procedures like Roux-en-Y reconstructions, certain colorectal resections, gastrectomies, liver transplants, all of them create potential spaces or defects in the mesentery that the bowel can just exploit. This trend really means that for many of you listening, if you see an internal hernia, it's most likely acquired.
Okay, and for the surgical audience, we need to pinpoint those specific high-risk sites. If you're performing a Roux-en-Y procedure, what are the defects you absolutely have to manage meticulously?
In any procedure with a Roux limb, there are two critical sites that are just non-negotiable. First is Peterson's defect. That's the potential space that exists behind the Roux limb itself, right up against the transverse mesocolon.
Right.
Second is the mesenteric defect you create at the jejunal-jejunostomy. These two sites are responsible for the vast majority of acquired hernias in bariatric surgery, and they demand prophylactic closure every time.
That is a terrifying risk. So to give us the best chance of spotting it, we need to know where these things hide. Let's get anatomical. What are the key locations and, their associated quirks?
Okay, so if we classify by location, the most common type is still the paraduodenal hernia. It accounts for over half of all cases, and we really need to distinguish between the two sides.
Let's start with the left, which I think is the most frequent of that group.
Yes, the left paraduodenal hernia makes up about 75% of that subgroup. It herniates into what's called Lanzert's fossa. And the key visual clue on imaging, the thing to look for, is seeing the entire small bowel clustered in the left side of the abdomen, often looking like it's encapsulated.
And the right.
The right periduodenal hernia that goes into Wall-Dyer's fossa, and it confines the small bowel to the right upper quadrant.
Okay, moving down the incidence list. What's next?
Pericecal hernias. They're about 13% of cases. These herniate into the retrocecal or ileocecal fossa, and this location immediately creates a huge diagnostic pitfall.
I can imagine. Pericecal location? Right lower quadrant pain? I mean, that sounds like a textbook case of acute appendicitis.
That is the diagnostic trap.
Yeah.
It often presents identically to appendicitis, which means the clinician has to keep internal hernia high on the differential, even when they're facing classic RLQ symptoms.
Yeah.
You have to question the obvious diagnosis. Then you have a smaller but very complex group, foramen of Winslow hernias, around 8%.
That's one where the bowel actually slips into the lesser sac, right?
Exactly. It goes through the epiploic foramen, which is bounded by the portal triad. Imaging here is absolutely key. You look for gas-filled bowel loops positioned medial to the stomach or signs of air in the lesser sac.
And the last major category.
Transmesenteric and transmesocolic hernias. Now, these are often acquired in adults after surgery, and they carry an extremely high strangulation risk because the defects are often wide, allowing a huge amount of bowel to herniate and twist.
So when we look at how these patients present, the sources talk about the diagnostic triad: pain, obstruction symptoms, previous surgery. But practically speaking, how often do clinicians actually get that full, neat picture?
Almost never. The pain is often intermittent and vague early on, especially in the acquired hernias, and this is what leads to those repeated ER visits and dangerous delays. The triad is a theoretical ideal. What you really need to listen for are the subtle chronic clues.
What's that single suggestive chronic symptom we should be listening for?
The sources really highlight this. Tingling postprandial pain.
Tingling?
Yeah, the patient complains of this weird discomfort or a sense of pulling shortly after they eat. It often suggests intermittent entrapment and then a temporary release. This is a huge red flag that demands investigation, even if the acute symptoms have gone away.
But the danger is that these subtle symptoms can give way to a systemic crisis with almost zero warning. What are the critical systemic warning signs of strangulation that just scream, "Stop talking, take the patient to the OR"?
This is the moment the textbook closes and the clock starts. You have to look for signs of systemic toxicity. Frank peritonitis, increasing tachycardia and hypotension, fever, and elevated white count, and critically, unexplained lactic acidosis. These signs mean established intestinal ischemia and necrosis. It requires immediate action.
This urgent need for confirmation brings us straight to imaging. The clock is ticking, the patient might be unstable. What is the definitive tool?
The consensus is absolute. A CT of the abdomen and pelvis with both IV and oral contrast is the gold standard. It's fast, and it gives you the anatomical detail and the vascular assessment you need to confirm the diagnosis and plan your surgical approach.
Okay, so let's talk about those aha moments on the scan. What are the cornerstone signs we need to recognize?
The most common finding is what's called the cluster or conglomeration sign. It's an abnormal encapsulated clustering of small bowel loops in a really atypical restricted location. It just tells you the bowel is trapped.
But the truly pathognomonic finding, the one that screams acute portion, is the swirl sign. Can you talk me through that?
Of course. For a resident reading that CT for the first time, what you're looking for is the appearance of engorged mesenteric vessels, fat, and the small bowel itself twisting. It forms a spiral pattern around the narrow neck of the hernia orifice. It looks like a vortex or a cinnamon roll on the axial view.
So the swirl sign is the smoking gun.
It's the smoking gun. It confirms the acute mesenteric torsion. It's direct radiological evidence of vascular compromise and a definitive indication for urgent surgery.
What about other supporting signs?
We also look for the mushroom sign, where the herniated mesentery and bowel look like the cap of a mushroom pushing through a tight neck. Then there's a sacculation sign, where the trapped bowel just looks encapsulated, often with fluid. And we also look for displacement of adjacent organs. Remember, posterior displacement of the stomach is a major clue for a foramen of Winslow hernia. And then, of course, you have the really late definitive signs of strangulation itself. Bowel wall thickening, mural pneumatosis, and portal venous gas.
Okay, so high suspicion is established. But what if the imaging is nonspecific? Given the risk of delay, when should a surgeon just abandon the perfect image and move to the next step?
When imaging is equivocal, but your clinical suspicion remains really robust, especially if the patient has that recurrent, severe, colicky, pain diagnostic laparoscopy is absolutely warranted. It serves a crucial dual purpose. It's diagnostic, you can see the defect directly, and it's therapeutic, because you can proceed immediately to repair. You cannot wait for a perfect image if the patient's clinical picture is suggesting evolving ischemia.
Let's move immediately to urgent management and technique. We have to stress this. There is absolutely no role for non-operative management in a symptomatic internal hernia.
None. This is an urgent surgical case, full stop.
So what are the immediate priorities before that first incision?
Aggressive simultaneous resuscitation. The patient goes MPO, you insert an NG tube for decompression, and you start aggressive IV fluid resuscitation. And if there is any suspicion of ischemia or impending strangulation, broad-spectrum antibiotics are mandatory. Something like piperacillin and tazobactam.
Once you're in the OR, what are the 3 key goals for the surgeon?
Reduce the hernia gently, meticulously assess the bowel's viability, and definitively close the defect to prevent it from ever happening again.
Let's focus on reduction. If that orifice is tight and the bowel is massively edematous, dusky, that has to be the riskiest part of the procedure. What's the safest technique?
It requires immense delicacy. You use gentle traction on the proximal bowel, you use gravity and patient positioning, maybe Trendelenburg, and warm saline irrigation to reduce the edema. But crucially, if that orifice is too tight, you have to resist the urge to just pull harder.
So what do you do?
The correct life-saving step is to carefully incise the hernia ring along the avascular or mesenteric border to release the neck. You never incise blindly, and you always prioritize avoiding vascular injury.
Once it's reduced, viability assessment is the next high-stakes decision. Beyond just looking at color and peristalsis, what advanced tools are there to eliminate the guesswork?
We should be relying less on subjective assessment now that we have these tools. The
Right.
sources really emphasize fluorescence angiography using indocyanine green or ICG. ICG lets you visualize true perfusion flow in real time. It gives you definitive proof of viability. If viability is still questionable, especially in a septic patient, the surgeon has to have a low threshold for planning a second-look laparotomy in 24 to 48 hours.
And when do you move from assessment to resection?
If the bowel is frankly necrotic, resection with a primary anastomosis is the goal, if the patient is stable. However, if the patient is critically ill, septic, or has severe peritonitis, you have to prioritize source control. And considering a temporary diverting stoma might be the safer approach.
Let's talk about defect closure, because this is the key to preventing recurrence.
Closure isn't optional, it's mandatory. Failure to close the defect is the single most common reason for recurrence. The closure needs to be done with non-absorbable sutures like polypropylene or a very long-acting absorbable suture like PDS. And here's a critical nuance. The closure must be done so meticulously that it doesn't compress or impinge on any adjacent mesenteric vessels. You can't create a new problem.
Moving on, let's compare approaches. The sources indicate laparoscopy is often preferred initially for stable patients. Why is that?
Well, it offers some significant advantages. You get a magnified view, better visualization of deep anatomy, less pain, and a faster recovery. It also allows for a quicker, more focused assessment of the hernia neck and its contents.
But the challenges of laparoscopy in this specific setting seem pretty significant, particularly with the mechanics of reduction.
Absolutely. The main challenge is the reduced tactile feedback. It's hard to know how much force you're applying. And reducing a massively edematous dark bowel through small ports can be extremely difficult. We recommend considering techniques like using a hand assist port for a complex reduction, which gives you back that tactile feedback, along with using only atraumatic bowel graspers.
So given that difficulty, where should the conversion threshold be set?
It must be low. If you can't achieve a safe, gentle reduction or you can't definitively assess viability laparoscopically, you convert. Safety is paramount, especially when you're assessing bowel perfusion. The sources show a high potential for conversion, sometimes up to 30 or 40%, because this pathology is just so complex.
Let's end by reiterating the prevention strategy for those acquired hernias. The data here is overwhelming, especially in Rousseau-Y gastric bypass.
It's the most powerful takeaway. We now have strong, compelling evidence that favors the routine, meticulous closure of both Peterson's defect and the jejunogenostomy defect during the initial RYGB surgery. Studies have shown that routine closure dramatically reduces the internal hernia rate from a baseline of around 10% down to less than 2%.
That reduction from 1 in 10 patients potentially developing this to less than 1 in 50, that is a stunning outcome. It fundamentally shifts the risk for the patient and really establishes a new standard of care.
It's the difference between an avoidable tragedy and optimal surgical precision.
So to summarize the core conclusion here, the successful management of an internal hernia hinges entirely on a surgeon's high index of suspicion, their astute interpretation of imaging. You have to know those signs like the swirl sign, and a definitive surgical repair that includes mandatory defect closure.
It's a condition that requires high vigilance and absolutely zero hesitation.
Our final provocative thought for you to mull over as you go back to your clinical practice builds on that challenge of the high conversion rate in laparoscopy. Given that you know the high potential for conversion and that a clear assessment of viability is life-saving, what is the optimal clinical balance point between maintaining a challenging laparoscopic approach for better patient recovery versus converting early for maximal safety and the clearest, most definitive assessment of that bowel's health? That decision point really defines modern surgical management.
That is the ultimate surgical dilemma.
If you found this deep dive valuable and think this clinical insight could help someone else facing this critical emergency, please do not forget to share it with at least one of your colleagues or friends to help spread the word. Also, check out our YouTube and other social media pages for more in-depth content and visuals to support your learning. We appreciate you diving deep with us.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.